So what I'm going to talk about, I changed the slides from what my handout was, mainly to talk more about the treatment options and some of the, make it a little bit more patient-centered. So localized scleroderma is actually more common, even though we see it less commonly in our clinic. We see a lot of systemic sclerosis, or regular scleroderma. But especially dermatologists and pediatrics see a lot more of the localized scleroderma. So you can see it's a younger group that gets it. And the average age diagnosis is about 33, but it's very common in children. So we often see in an adult clinic a lot of people who had the disease as children who now come to us 20 years later and they're not sure if, say, a lesion is moving up their forehead. So for us, it's very tricky to just figure out when the disease started, whether it's progressing. And it can last for years, come and go. So unlike systemic scleroderma, where it seems to follow more of a pattern, we're often struggling with figuring out the beginning and the end of these lesions in the localized scleroderma. One of the main things about localized scleroderma, all the forms of it, is how it can look like scleroderma, and the skin lesions under the microscope look identical. And even some of the skin, when you take a look at a patient's leg, for example, and you feel the skin, it looks like the same as what you'd see with the systemic sclerosis, but it's much more patchy. And in some of the associated conditions where you see the differences, patients very rarely will have Raynaud's. It's not associated. So as soon as I see a patient who I don't know what they have, if they don't have color change in response to the cold, then I'm thinking it's either localized scleroderma or a scleroderma mimic. Very rare heartburn. It can be associated with an anti-nuclear antibody, the ANA, which is a test for lupus. Very common in scleroderma. Less common in morphea. No associated lung disease, like pulmonary hypertension, interstitial lung disease. And I used to always think of this as the good type of scleroderma to have because it's not associated with death. When I first started seeing patients with our mentor at BU, it was about 2003, and I saw a lot of patients who were rejected from life insurance because they had scleroderma written. And we just corrected it to morphea, and everything was fine. So I thought this was good. But as you'll see from the slides, this can be a disfiguring, horrible disease. So a couple different types of morphea. The plaque type is the one that we see more in adults, whereas the linear form is much more common in children. Deep morphea and the generalized form can really mimic the systemic sclerosis and can be really tricky. People who have that suffer from a lot of joint contractures and the same problems that the adults with the diffuse form of scleroderma have. So the words between localized scleroderma and systemic sclerosis, both being called scleroderma, is very confusing because they are really different diseases. Scleroderma means hard skin, and as I said before, on the skin biopsy and just on physical exam, the areas that are involved are often identical between the two different forms. I try to talk to patients and say morphea more often, even though that's a subtype of the localized scleroderma, just because it's so much less confusing. We really have a problem with patients who even go on the internet and try to figure out what disease they have. Calling something linear scleroderma, limited scleroderma, localized scleroderma is very confusing. So I use the term morphea sort of interchangeably. The other problem is you're going to see from some of these pictures, and some people out there may have actually experienced this, is that when the disease has been present for a while, you can get a deep sort of a divot in the skin, so a very sharp cutoff, almost like a canyon forming in the skin called atrophy. And that can be horrible because just cosmetically the skin sort of sinks in. But that's not something we're very good at treating. It's very hard to stop it. That's sort of the end stage. For patients with diffuse scleroderma, sometimes when you're pinching the skin, that's considered a good outcome, and that goes from your modified skin score of a 3 down to a 0. And so in research trials, that looks good, even though cosmetically you're not happy with it. So it's very difficult because that's very common in this disease. So you have it for a little while with a little bit of skin thickening, and then the skin, the fat, and the other layers of the skin actually shrink down. as you can see here, I just use this slide because in adults, the plaque type morphea is much more common, whereas in children you'll see more of the linear, which is sort of just one arm or one part of the leg on one side of the body affected by it. But when it crosses a joint, even though it may just be a small area, it can be associated with joint contractures. And there's another part called Coupe de Sabre, where it looks like a saber went in the forehead, and that's a very common form of linear scleroderma. So here's probably the most classic picture of what we call morphea. You can see the ring around here. Sometimes it has a violaceous hue. We try to biopsy from that area to see if the lesion is active. If you press with your fingers and try to pinch the skin, it's often very thick. Sometimes there's a shiny appearance to these lesions. These look very active at this point. When the disease persists for a while, sometimes what happens is you'll get the atrophy and these areas will sink down. Other times you may not be able to pinch anything, but you'll just see the hyperpigmentation. And those look like early lesions, but sometimes they just stop and you'll just be left with something that is a little hyperpigmented and it just ends there. There's a high association with genital, so especially vaginal lesions called lichen sclerosis. So it's dry skin in the vaginal area that the GYN will often pick up, and there's a very, very close association between these two diseases. I actually think they're probably the same condition expressing itself differently. Not everyone with lichen sclerosis will get morphea, and not everybody with morphea will get this, but they do associate very closely. So we always ask about that. There are a lot of other autoimmune diseases, but not usually the ones that we see with scleroderma. You don't see the muscle involvement, you don't see rheumatoid arthritis or Sjogren's syndrome or lupus, which we see in scleroderma. But you see thyroid disease, you see uveitis or eye inflammation. And there's a condition that's not very well understood called atrophoderma of Pacini and Perini, which is a lot like the end stage of scleroderma, of this disease. So instead of getting the skin thickening and then getting the atrophy and the cutoff and the sunken skin, you go straight to the sunken skin. So whether this is actually exactly the same and it's a very brief area where the skin gets thick, or whether it's a completely different disease, we're not really sure. I consider it part of it, but just a very unusual form. This one here is called Guttate Morphea. What you can see is it's actually really hard to see on the slide. But it's just sort of a patch here up on the arm. And there's just little speckled, small little dots of shrunken skin. This is one that, as you can see, the skin is tight, it's very firm. It looks like a lot of the diseases where people have trouble with blood flow and the skin will turn hard, but you can see that there's little blisters on top. This is a very rare but very bad form of morphea. This is a good slide of the linear scleroderma where you can see that one leg is normal. On the other leg, you're seeing tight skin. It's very thick. If you press with your fingers, it's hard to get a nice little pinch of skin between your fingers. This is another form. This is common in children. You can see it in adults. But as you can see, it looks like a cut from a saber, usually just to the one side of the midline of the forehead. And it can almost appear overnight, just like this. And other times it starts as one small area that you think, oh, did I hurt myself? Did I cut myself? And then it progresses up into the forehead region. And a lot of times people aren't, when they see me, they're not really bothered by the actual skin lesion. But as it starts to go back and they start losing their hair, that becomes a problem. So this one's very interesting because unlike, this is one of those places where this morphea is associated with neurological conditions that we don't see in the systemic form of the disease. This condition is often associated with seizures. You can get eye involvement, but there's a lot of neurological involvement here. There's another form of this that's very rare called Parry-Romberg syndrome, where it involves one side of the face. You can see the sort of atrophy of the skin over here. And when this happens in children, it causes not only some neurological side effects like seizures, but it can also cause a problem with the underlying bone and growth. So one side of the face may not grow completely. So this is something that you treat very aggressively when you see it in the clinic. We usually use high-dose steroids, methotrexate, strong chemotherapy, and then the plastic surgeons can do some fat transplants. But interestingly, there's an association with trauma. So some people think that if this occurs after some mild childhood trauma, that a kid will injure part of the face in a fall and then develop something like this. But obviously, kids get into accidents all the time and don't develop it. This is a very, very bad case where you can see just how the morphea is now involving the jaw and the muscles underneath it, and her face hasn't grown completely, and she has a growth disturbance on that part of the face. And you can see the Coupe de Sabre lesion extending into the forehead and the hairline. So nowadays, if this was to happen in Boston, for example, where I work, we would probably have the patient go see Children's Hospital and some of the cosmetic surgeons to work on some implants. But there's always the thought that if you do the implant at the wrong time and it's still active, it may actually make things worse. But we don't know. We're not at this point where we can ever say to somebody, it's over, you're done, now we can do the surgery, or whether they're at risk for this reactivating. That's a common clinical question, is when does this end? When are we sure that it's over? So this is one case that sort of is something we never see in systemic sclerosis, the full diffuse or limited scleroderma. This was a 18-month-old child who fell off the top of the bunk, hit his head, and then developed that Parry-Romberg syndrome very quickly. Then a couple of years later, he had eye inflammation, uveitis, which is inflammation in the front part of the eye around your lens. And then the left side of his body had trouble moving. They saw some things on the MRI, and then he had something called alien hand syndrome, which is where patients describe it. It's something that's been seen after strokes, and what happens is you could be sitting at a table and your left hand, for example, moves, but you don't feel like you're controlling it. And it's doing things on its own. And it's something that can start when the two hemispheres of the brain are split. So it's well described in neurological literature, but obviously it's not something we see every day. It's a very unusual form. But there's a lot of reports of this happening when people have morphea involving the head and neck. And we never see that in systemic sclerosis, so clearly there's a large difference between the two diseases. This is probably the worst type of most intensive skin involvement in morphea. And this is very rare. The difference is when you see a patient in clinic, when you start to think that this is a morphea version rather than systemic sclerosis, because it looks from the distance just like regular scleroderma. The difference is often it will spare the hands, and when you see a patient with systemic sclerosis, it almost always starts in the fingers and works its way up. This could have started, say, on the leg, then moved to the other leg, and then moved to other places, and the hand is not the first place that would start. The other thing is the patient would not have Raynaud's, would not have interstitial lung disease. They don't have the digital ulcers or problems with the vasculature that you would see in systemic sclerosis. But every time I see a report of this, or even this picture with her hands like that, I suspect that maybe this is systemic sclerosis and not morphea. So I almost have to see these cases myself to really believe that this isn't the other form, especially when they start saying that the patient had pulmonary hypertension or interstitial lung disease. And this one just is very resistant to therapy, so we try everything, and with a lot of these morphea subtypes, we've thrown the kitchen sink at them, and every doctor has done things differently, so when I get to the treatment, you're going to see that we're starting to just standardize our treatment protocols so that we can actually investigate this condition. I just sort of went over. So yeah, even if that woman had a positive ANA, I'd still think it could be generalized morphea if they don't have the Raynaud's, they don't have the nail fold capillary changes. I don't know if when patients, if you go to the rheumatologist, if they put the mineral oil on and look at the blood vessels in your fingernails. That's something we often see in the systemic sclerosis that you never see in morphea. So this is an outline of what treatment was. This was a recent study done by a lot of pediatric rheumatologists and dermatologists who see localized scleroderma. And what they were trying to do is just get a room full of experts who see this disease to come up with a couple of standard therapies. And this is what they were doing before they met with the drug methotrexate and prednisone or IV solumedrol, both types of corticosteroid. And everybody had different regimens, and they decided to come up with just 3 different ways. Methotrexate, and this is a much higher dose than what we use in adults. No steroids, 2 versions of intravenous steroids, IV 3 times a month, or IV once a week for 3 months, and then or oral prednisone. And this became our standard of care. And this is probably the best evidence-based regimen for treating people with really bad localized scleroderma. When you have the plaque-type morphea, just a few spots, something on, say, the back, it's not very cosmetically noticeable. There is a lot of literature saying that you can use topical creams, you can use topical steroids. We tend not to see those patients because we're rheumatologists, and the dermatologists see those patients more often. They also use light therapy a lot more often than what we see. We see more resistant cases in our practice. So usually this is what I go to right away. I usually will decide if it looks really active. If somebody looks like they're progressing really fast and you just want to throw your most aggressive therapy with them, we give the intravenous steroids once a week for 3 months, and the methotrexate. Experimentally, if you don't respond to that, then pretty much everything else is possible. There are case reports of almost every drug working in this. Probably the safest and most well-used, most well-studied for people who fail that first regimen is using mycophenolate or Celcept. It's an oral drug you take twice a day. Especially in pediatrics, this is a drug that's used quite commonly because it doesn't have the side effects that you'd see with cyclophosphamide or some of our other drugs. Some of our other therapies, light therapy, phototherapy, specialized centers will use UVA1 therapy. You often have to go into a box if it involves a whole part of your body and stand there pretty much naked for an hour or 2. Yeah, sure.
So when UVA, so that is UVA is used for scleroderma patients and it's successful?
I think with this disease, it's very hard to tell when we've had a success because we don't have a placebo a lot of times for this. You could study with that, but it's very hard. It's such a rare disease, and as you'll see with some of the outcome studies, it's very hard to tell if you just stopped the disease, whether it stopped on its own and your treatment was ineffective, or whether you're slowing it down. So it's very hard to study this disease. We think it works, but it's tricky. In our group, we haven't seen a lot of success with either the topical therapy or the light therapy, and it may be because that's the subpopulation that we see. We see people who often started that already and failed it. So it may work in a subset of patients. The tacrolimus ointment is widely used, and a lot of patients say that they thought it worked, but usually they were started on it before they saw me. So it's not usually something I start.
Like, just for the future, like, there, just to know if it makes a difference if people start earlier in their,
I think this is just like regular scleroderma. Once we find a drug that really works, we're not going to argue anymore over whether we started early or start late because we're going to see obvious improvement. This happened in rheumatoid arthritis when we got these newer drugs, like the TNF inhibitors. You went from sort of arguing over small changes to, wow, your disease is gone and you can still run triathlons and you're not disabled and you have to lose your job. So it's been revolutionary working in a rheumatology clinic between the patients who were treated before we had these newer drugs and now, and I hope within 10, 20 years we're going to see the same thing in scleroderma, that one of these drugs is just going to be lights out, it's going to be clear it works. With this disease, I do think compared to the scleroderma tox, I do think there's potential for just an ointment or a cream to really sink in and work. So I think there's going to be some drugs that come along that will have novel mechanisms of action. One of the problems with studying both types of scleroderma is that we don't have very good mouse models of the disease. We don't have mice that get skin thickening in response to this. We do know, and I'll talk a little bit about it, of some things that humans have accidentally taken that have caused a similar disease. So maybe we'll learn from that. So the first thing that I do when I see a patient with localized scleroderma or morphea is try to figure out whether this is somebody who's already gotten to the end stage of the atrophy, which is mainly surgical correction, the people who have the sunken skin, or whether they have lesions that I think are going to be amenable to treatment. So when I pinch the skin, I try to figure out whether it's thick, whether it's inflamed. Sometimes it's really hard to say. Taking measurements is very difficult because it can skip a few areas. Sometimes the borders are very indistinct. If you have new joint contractures, hair loss around the area, I think that's very active. But often, no matter what we do, the disease just stops. This isn't a cancer. Even the scleroderma has the same problem that the disease one day will just go away, and we don't know why that is. We can't predict it. So we sometimes think when we have small studies there, we have a wonder drug because it stopped in a couple of patients. But if you compare it to a placebo, it's probably the same. So this one, there's another form of the disease called eosinophilic fasciitis, and I put it in a separate category because to a lot of dermatologists, they consider this a totally separate disease. It comes on very quickly, often in very athletic people. There's an association with triathletes, people who have been working out a lot. It looks a lot like scleroderma. It's interesting because 40% of the patients who have this will also have localized scleroderma, so I consider it a form of morphea rather than being distinct. It does have a couple of unusual things. It's more often associated with a positive ANA, and you have a blood type that's involved in infections, especially parasitic infections, and drug allergies. So these eosinophils are seen if you get an allergic reaction to, say, a medication, or if you have an infectious worm from going to the tropics. It's a lot deeper in the skin than what you see for morphea, and often if you just look at the skin and you even pinch it, it feels normal. The disease is actually involving the underside of the skin, something called the fascial layer, which is below the skin, the fat, and around the muscle layer. There's a connective tissue that gets very thick. And so this is sort of a classic finding of the groove sign. If you lift somebody's arm who has this, the places where you have veins will collapse and you'll have a groove right there. I don't know if you can see that. Does that come out okay?
Yeah.
Yep.
Can you just break down what that means?
Eosinophilic fasciitis. I was hoping you weren't going to ask that. All right. So peripheral eosinophilia is just a subtype of your white blood cells that normally we have circulating in our bodies at very low numbers. And we can see very high numbers of this associated in people who have this disease. And if you take a skin biopsy and it's deep enough, you can see that the eosinophils are actually in the area involved with the skin tightening. But if in this picture, for example, if you were to pinch the skin, okay, the skin often feels normal, but it's very, very tight. And you can tell it's very thick, but the thickness feels deeper than what you normally see. And compared to people who have scleroderma, I don't know if you remember the linear scleroderma of the leg, usually the hair is gone. The hair will stay the same. We see a lot of this referred to us for evaluation of systemic sclerosis, and you can tell right away by just looking at the hands that it's the forearms and the calves that are involved, but the hands are normal. And that's usually a sign to me that I'm looking at a mimic, and I think of eosinophilic fasciitis. You can have decreased range of motion because it can be so thick that you can't move your wrist very well. So if you have people put their hands together, they sometimes can't completely close them. They get something called a prayer sign. And there's a muscle enzyme called an aldolase that is increased in a lot of patients with this. And a lot of times we see people who have both this and Morpheus. We treat it the same. This is probably the best type of disease that we'll talk about today, because even though it needs sometimes years of prednisone, it does get better. Almost every patient has improvement in their disease. I haven't seen anybody. I've seen people who have gone from being very fit. U.S. Marine came to me and he couldn't do push-ups, and that was his first sign of it. And then after a lot of prednisone, he was actually able to go back, but every time we stopped the prednisone, the disease would come back. So I often tell people that you might need years of prednisone, but this is very treatable. Yes?
So in that area where you said the vascular structure is completely collapsed beneath the skin, is the circulatory structure also diminished to the degree that you're not feeding the part?
No, that's a good thing about this. What this is just the skin is so tight that when you lift the arm, the veins collapse, but the skin around it doesn't change. So this is just from raising the arm. It goes back to normal as soon as you put the arm down. Yeah. Sometimes, if anybody's ever been on prednisone, you know that as soon as you get on it, even though it might be helping, the first thing you want to do is get off of it or get to the very lowest dose you can. Because it can cause osteoporosis, it raises your blood sugar, it causes infections. It's really a horrible drug, but it works so quickly, and in this case, it does work very effectively. So we try methotrexate, we try some of these other newer agents that we use for other diseases, but the jury's still out as to whether they're useful or not. It has overall a very good prognosis. It probably has the best outcomes of all the diseases we see. Now, when you get diagnosed with either scleroderma or morphea, you often wonder what causes this. Is this genetic? Is this something that I've, in my diet, anything I've been exposed to? In localized scleroderma, there are a couple of associations that are incredibly rare, but we know that there is something out there that causes this syndrome. So in patients who have breast cancer and get radiation, there's a form of this called breast-associated morphea that causes a lot of skin thickening in the radiation port. And radiation oncologists will see this quite a bit and be very nervous to give radiation to scleroderma patients, because if you have any form of scleroderma and get radiation, it can often activate the disease. We're not really sure why that happens. Strangely, in Boston, where we see a lot of Lyme disease, there's a lot of reports in the literature of an association between morphea and the infectious agent of Lyme disease. But almost all those reports come from Europe, where they have a different strain of Lyme disease. And I routinely check patients for Lyme disease when I see them, and I've very rarely seen it. So we have an endemic area, and if it was truly associated, I think you'd start to see, in places where you see a lot of Lyme disease, you'd see a lot of morphea. And we don't see much of a difference across the country from places that don't have it and places that do. So I think, even though that's talked about, I don't think it's a true association. Then there, trauma, from that first case, the kid with the alien hand, there is something about maybe injuring the skin either through radiation or from physical trauma and causing it, but everybody hurts their skin. Everybody gets bumps and bruises, and this is still a very rare condition. So it's not really clear what happens, but we do know that when we do surgery on people in the area of their involved skin, that sometimes the disease reactivates and gets worse again. So surgeons can be very nervous about touching those areas. And then environmental, I'm going to talk about two really weird conditions, toxic oil syndrome that happened in the 1980s in Spain, and this new osteoporosis drug that caused morphea in a small number of patients who got it. So toxic oil syndrome was this really weird thing that happened in Spain when people took industrial oil, made some chemical modifications to it, and then sold it on the street out of milk jars, milk containers, as canola oil. Or it was sold as olive oil, but people put it on their salads, and 20,000 people were affected by this, and there were 2,500 deaths. And it caused this really hybrid version of systemic sclerosis and morphea. It had, the skin lesions looked more like morphea. They didn't have Raynaud's. They had the high eosinophil count, but they also had lung disease, which we don't see in morphea. And interestingly, if they took the oil and gave it to mice, the mice were fine. And a lot of humans who got this were fine too. So we've studied it, but we don't know exactly what happened. So what happens, it's really interesting, they did a lot of studies, is they found that the initial truck came from France, it entered Spain, and then they made a couple of changes to it, and then they know where each of the changes to the structure of the oil came from. And then when it, oh sorry, I thought I had it here. There was only a certain part of the population that got the final version, and they were the only ones who got sick. So they know all the modifications, they know where it was sold, they know a lot of people who were exposed to it who are fine, and other family members in the same household who had the same exposure were told were, died from the disease, and other people were fine. So we don't really understand the syndrome. And here's how it changes, how it differs from other forms of scleroderma. So compared to morphea or eosinophilic fasciitis, it has some features, but it also has some features of scleroderma. So people have been trying to study this now for 30 years and haven't made much progress. And then this is another drug that came out more recently. This was a clinical trial in women who had osteoporosis. And out of 709 patients, 7 developed localized scleroderma. And it caused very thick skin, usually in these cases around the breast, but other body parts were affected as well. And as soon as they stopped the drug, the lesions got better. So it's a rare association. It's still not everybody who took the drug got this, but why these patients did, we don't know. But it's probably not going to be used. And the interesting thing about it is the target of the drug isn't seen in skin, or at least they didn't think it was supposed to be in skin. It was only supposed to be in the bone cells that break down old bone and start the process for making new bone. So we don't know if it was some metabolite that may have caused the problem, whether it was sort of an off-target effect, or whether this cathepsin K molecule is actually involved in skin. So it's pretty interesting. Anybody who has any questions, feel free to email me. I can email you my slides, just send me something. And I'm available to talk if you have any personal questions that you want to go through.